Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts. Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook. On this episode of the Next Breast Thing,
the renovations have officially started, so
things that I have ignored during my training. So
we sometimes don't find time to carve out a little bit for ourselves, and this has become the highlight of my
retirement plan is based on.
And we're talking about how to crack the code of reimbursement and what that presently the overwhelming majority of physicians in the United States are employed.
It's a topic that unfortunately physicians don't know a lot about.
If you're working for an hour and getting $25 and then that changes to $12.50, it's going to change how you do things. And like when you have someone with a really aggressive cancer and you're like, what? This other case is a zero off. They don't have cancer and I have to.
It really does kind of irk me that we are calling somebody to ask for permission to do what's best for our patient, and we are at their mercy, and it kind of drives me crazy.
This is Carla,
Ellie,
Michael,
Susie,
Sitcha,
and Susan. Welcome to the Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
From advances in procedures and patient care
to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.
Our topic today is going to be how to crack the code of reimbursement and how it affects everyone, not just physicians. But before we get started, let's begin again with some personal and professional updates. Carla, let's start with you for a change.
Well, the renovations have officially started, so I'm currently commuting about an hour to work, which I know is nothing for some people, but I already have a driving-related injury. I have a lower back pain from sitting in my car for so long. But
Carla, it gives you more time to listen to our podcast.
I have been listening to our podcast, and I love it. It's a great time to listen to some audiobooks and this podcast. So I've been really enjoying it.
Carla, I heard that meditating in the car while you drive is really great.
You know what's funny? I was actually thinking about that.
And now you see what
I was like, no, I'm not going to. But I really did, because I was like, I need to meditate more. I've got these extra 2 hours. But yes, I did.
You can see how it happens.
Susie, what about you? What's been going on? My niece had twins, so they went from a family of 4 to a family of 6. And so that is super exciting. Then I'm continuing to play Mahjong. And anybody who does not have something that is not related to work needs to find it. Because I think physicians, we take care of our patients, and our family. And then we sometimes don't find time to carve out a little bit for ourselves. And this has become the highlight of my week.
Susie, what is Mahjong? I know nothing about this.
We're dating ourselves by knowing what it is.
It is a game, and there's tiles. They're kind of like Scrabble tiles, but they have characters on them. And it's a lot more complicated than something like Rummy. And you play with a group of people and you can bet. So those gambling people on this podcast, you too could make 25 cents in a night. I know that's a little bit lower than Old Vegas. It is a fun game. It took several weeks for us to all catch on. Sitcha, what do you do for fun and what's new with you?
I have 2 toddlers, so that is about all I do. I think I mentioned last time I was planning my daughter's 2nd birthday, Chanel number 2. She had a blast. She turned 2. She's just growing so quickly. She's so freaking cute. Lately, she's been going around saying that she's 4. And so I keep telling her, no, honey, you're 2. And she says, no, I'm 4. And then lately she learned half because my son is 3.5. So she's like, I'm 4.5. She like doubles down and keeps going up. Every day she says that she wants to start going to school. So we're looking at some daycares for her. We took her to my son's daycare and I think she'll fit right in. She starts playing with his friends and his toys and he loved it and she loved it. We're just waiting for cold and flu season to come down a little bit. It's definitely warmer here in the Northeast, but still just one cold after another with these two kids. Just waiting for those to get a little bit fewer and farther in between and we'll get her enrolled in school soon. What about you, Ellie?
I have kind of made it this year's mission to spend a lot of time on things that I have ignored during my training. So kind of life skills. So I recently went to a real estate investing conference that was targeted at physicians, but I learned a lot about accounting. I learned a lot about financial planning and just kind of the boring stuff, but stuff that I really didn't get a lot of in training. And it was extremely helpful. So I actually learned a lot. I got a lot of connections, people that could be a part of my team in the future. I remember when I was at the Fellow Institute, Susan mentioned the importance of having a team around you as you start building your practice and getting more ingrained in your community, how you really need to have a team of people that's guiding you. Because obviously we can't be experts in everything and there's always something to learn from every profession. And I got connected with a lot of people like that. I learned I still need to do some reading and kind of expand my knowledge. But yeah, it was very interesting and eye-opening. Another part of life that I haven't really been exposed to, which is real estate.
Ellie, that's amazing. When did you finish fellowship? How long ago was that?
3 years ago.
3 years ago, and you remembered that from the luncheon. Now, I remember saying it because I really do feel that way. Just like at work, we have a team. How do we think that for our finances and insurance and all these different things that we don't have a team? So I'm impressed. You made me smile by remembering that I said that and that it had some sort of impact. So I appreciate hearing that.
Yeah, no, it did. And it was honestly the first time I had heard another surgeon say that. You just assume that everybody has it figured out, but actually a lot of the most successful people have a team behind them. So thank you for helping everybody.
I'm giving a similar talk in about a month or so at the Fellows course again. So
awesome. Well, keep it up. All right, Michael, what about you?
Well, I don't do those conferences because all I do is hear about what I didn't invest in or I didn't have a strategy.
it is all about the strategy.
No strategy. I didn't start early. No, I was busy, I thought. And so now my entire retirement plan is based on going to Vegas. I'm 37 YouTube videos down on craps, and I've realized I can't count that fast. So now I'm shifting to roulette and the strategies of roulette. And so I'm excited about that. That is my new shift in Old Vegas.
Can I give one more game suggestion?
Yeah.
Michael, it's really easy. 3-card poker and play blind.
Okay, right there. I have no idea what you're talking about.
It's just so easy. You just put money down and sometimes you win.
This is my retirement we're talking about here. It's not I have to win every time. All right. My whole retirement is based on this.
Yeah.
Okay, Susan, you're going to take us to Old Vegas. But until then, what's been going on?
So we are deep into meeting season. So it's just living deadline to deadline about when our presentations need to be submitted. I had one this past Monday and I have one tomorrow. So
there's deadlines?
There's deadlines. And actually people like when you stick to the deadlines. I've learned that. And not all of us are as good as Carla is.
Thank you.
With the deadlines. I'd like to recognize that you are probably the best person with sticking to deadlines that I know.
Well, thank you. That makes me smile.
She's a rule follower.
I am.
There you go.
Yes. And some are better rule followers than others, but some rules do make more sense than others. I will go with that. I like to follow rules that maybe make sense. So let's move on to the topic. And again, we're talking about how to crack the code of reimbursement and what that means for not just us as physicians, but for our patients. And behind every breast surgery is the unseen world of reimbursement. Behind every patient appointment is an access issue. And as some of you may know, Medicare was just voted in for a 2.83% pay cut. This is nothing new. This is not a political conversation. This has been going on for years. If we go back to year 2000, 2001 to now, physicians for Medicare, it's not just physicians, it's Medicare, it's been cut by about 30% if you take inflation into account. And the question is, who does that affect and how? And the thought is that it just affects physicians, and I'm not quite sure that that's the case. So Ellie, what are your thoughts and experiences? You're newest in practice of any of us, so you have a slightly different viewpoint on this.
I will say I'm not a private practice physician, first and foremost. So I am hospital employed. So my pay comes through me, through the hospital, basically. I don't directly see the Medicare cut.
Presently, the overwhelming majority of physicians in the United States are employed.
Right, exactly. But I do notice in working with my fellow plastic surgeons, that's kind of the first time I noticed that the changes in Medicare affected patients' ability to have access to certain physicians. So I would notice that I'd want to send a patient to one of my plastic surgeon colleagues who recently had to stop accepting Medicare or supplementing their practice with different types of insurances because of these cuts. They were not able to pay their staff. They weren't able to keep the lights on, essentially, because of these Medicare changes. Also, when Medicare changes, a lot of the insurances follow. And so I also noticed that more and more of my reconstructive plastic surgeons were falling out of the game because they couldn't pay their bills. They had to go into cosmetic surgery because of the reconstruction reimbursement being so poor. They just couldn't make it work economically.
I think it's pretty shocking when there is a cut like that for a patient to understand how many people it takes to get them from point A to point B. So for instance, at surgery, it might be 13 staff members that are interacting. And if we are not able to support the staff, keep them satisfied, and if staff are rushed and they have too many people in a small amount of time, it really creates a different atmosphere in the office. And I think also in particular with breast surgery, this is super important because these are people who need time. They need time to digest all this information. And even in the office, if you're not having someone who greets you, who is there for you from the very first person, that whole visit kind of gets skewed. And I agree, it's not about the physician, it's about the whole institution and be able to support a really good visit so that patient has a good outcome.
Sichka, you live in a high cost of living area in New Jersey. It's no secret. It's more expensive in these areas. How do you see this affecting patient access and care?
I've definitely heard from patients tell me that the diagnostic mammogram costs so much. Can I please order them a screening mammogram instead? I can't in many situations, obviously. It's a topic that unfortunately physicians don't know a lot about or don't learn a lot about unless you're like Ellie and you make it your point, or like you, Susan, and make it part of your career. I was actually looking forward to hearing what this actually means for us and really for our patients, because ultimately that's really all it comes down to.
Carla, you run a division. How do you see this affecting access? I can tell you in the New York area, if you're trying to get into a primary care doc, it is 9 months. That seems to be the magic number, is 9 months. So when we're trying to get pre-op testing, we have to make multiple phone calls from that. So this is affecting every aspect of care. How do you see it in being a leader in your area?
There's a lot to unpack here. We think of reimbursement as how much a physician or a hospital gets paid for a procedure, but there's so many different aspects to it. And so I think we had a good lead in with Ellie sort of talking about a financial team. We've talked about our healthcare team. And one of the things that we learned about getting an MBA, and I think, Susan, you're going to be pursuing it. But one of the things that we did in my program was we looked at healthcare systems in other countries. And I won't sort of dive into that too much, but you learn that it's multifaceted, right? So cost is what we're talking about, but cost affects quality, cost affects access. Those things come down to value. And I think that you can lower the cost of things, but that has a downstream effect. And so coming back to where I'm sitting as a division chief, as Ellie talked about, and Sitch is in a situation as well, in academic medicine, being hospital employed, there's a lot of different factors that affect our daily life. So we're not going to see those reimbursements affect us tomorrow, but those things will sort of have a downstream effect. And I think there's other challenges right now in terms of academic medical centers and education that we're trying to do the same thing with less. And I think most people know if you're working for an hour and getting $25 and then that changes to $12.50, it's going to change how you do things. But I do think the example about the plastic surgeon is a great one, right? Because we know that insurance companies are going to cover reconstruction, and that's been a law, and we're really thankful that our patients have that. But again, situated in the middle of Indiana, we are a catchment for the area. And so I get patients who are coming from Gary, Indiana, which is a 3-hour drive, when Chicago is right around the corner because of the way their health insurance works and what their plastic surgeons will cover. So yes, so many things that this affects.
Michael, what's your experience? You're in a different area of the country. How do you see this affecting care?
So we're in a private practice multidisciplinary group. So when the physician reimbursement drops, it's harder for us a little bit to wash it out than if we were employed. The big thing that we're really feeling is the payer mix. When I first started in this group about 15 years ago, about 15 to 20% of our payers were government, whether it was Medicare or Medicaid. And you just sort of say, well, we're doing okay with the private stuff. We'll just make up for it. Well, now our payer mix is 60-40 government versus private. We're in kind of a poor part of the country, but I think we're seeing more and more of that as people get older and as the economies go up and down. I think we're seeing the payer mix really broaden out, and these things really do affect us on the bottom line. And I think there is a feeling out there, well, I'm in a hospital, so I get paid but what I get paid. But this is affecting everybody down the way. We were in Washington lobbying against the cuts, and one of the people that were with us is in Louisiana, and they're in a community hospital. So they take whatever comes in, and some of the hospitals that were more private would then refer away from themselves some of these patients. And so they're really taking hits as their payer mix goes up and up and up. So I don't think anybody can really be buffered from this or immune from this. Mm-hmm. We all feel it, whether you're private practice or university or hospital employed.
Yeah, I think that everyone's brought up great points. Susie, if we were to switch gears for a second here and talk about things that really affect patients, can you talk about the difference between a screening mammogram and a diagnostic and the difference in cost for patients? Because I see this every day.
Typically, screening mammograms are covered and there's not really a cost associated with them, don't need a prescription. They can call in as long as it's within the time frame. But a diagnostic mammogram, for me, it's a really special tool because you can say, okay, at this time, I want you to get a diagnostic mammogram, whether it's because someone feels something different. There's been a change in exam. Some people do them 1 year post-op so that the radiologist is there available to do extra imaging if they need to do an ultrasound at that time. And you can get all that workup done at one time. Versus a screening mammogram, you get your 2 views on each breast. And then if something comes up, you get a phone call and then you come back and schedule a diagnostic. And there's a huge variety within centers of how fast you can get in for a diagnostic. It is a big deal. And if people are paying for that out of pocket, and I honestly don't know a cost for that, right? Because it's different for different people with different insurances, but there is always a fee associated with it. And for some people, that can be prohibitory.
If a woman has to choose paying for her ultrasound or putting food on her kid's table, we all know what that choice will be. They're going to choose to take care of their kids every day or take care of their family every day. Carla, do you see this where you are?
I was going to ask sort of what the ideal turnaround time would be for diagnostics, because I think maybe we don't have to all get into those numbers, but I will say that we could do some shorter turnaround times from the screening mammogram to the diagnostic. We serve a wide breadth of patients as well. And so I know we have a variety of people who listen to our podcast, and obviously payer mix most of us are familiar with, but it sort of reflects the different insurances that the patients that we see have. And some of us see patients who don't have insurance. Those patients do have some access, albeit much different. And obviously we have government, Medicaid, Medicare, if you talked about, and private. And we've seen kind of the same shift in terms of our payer mix that has shifted significantly. And those cause significant shifts in the amount of money. You know, medicine is a business. There's money that comes in and there's money that goes out towards the patients. And it's a delicate shift that is unfortunately shifting away from what we'd like to see.
Let's switch gears for a second. And I'm interested in everyone's thoughts on another big bad topic of pre-auths, prior authorizations, or however we want to call that term. Any good experiences with it?
Oh my goodness. There's no way anyone has a good experience. Someone would speak up first if you have a good experience.
I think this lends to how important the team-based approach is. I'm just so thankful that we have an amazing financial counseling team at my institute that helps with all of this. One of our issues right now is one of our radiology centers recently switched from being a private-owned entity to being hospital-based, which has changed everything. Oh, my Lord. I'm getting MRI denials, not for the test itself, but for the location.
The facility.
Now I just lost 2 weeks on that, and now I'm putting another prescription in, waiting another however many weeks for another approval for another facility. It's delaying care. It's a problem, and no bearing on our financial counselors. I think they do a great job. It's the system. And I understand the concept. I understand the hospital has its own fees and that raises the cost of the care at a hospital-based facility, but it's really causing a problem for us right now. And it's very, very new for us.
That's hard. And another thing that I think is so hard is when I hear back, I need a minimum of 21 days to get this authorized. And you know, like when you have someone with a really aggressive cancer and you're like, what? This other case is a 0 auth. Like they don't have cancer. And I have to wait, like, what can I do? We've all been in that situation. I used to get some sort of day before, like, this hasn't been authorized yet. And it's like, nope, we're going ahead. This patient has breast cancer. And I've never had a lumpectomy and sentinel node denied. Oh, I totally agree. But that's scary for a patient to check in and say, you have to sign this form that you may be responsible if this doesn't get approved, and say, oh, come on, they're going to pay for your breast cancer. I mean, this is not me writing that check. This is someone who's really vulnerable. But I completely agree, Carla. Like I push, and I say, I know it's going to come through, and I have such faith in you because you are so good at your job. You are a part of my team, and I know this is going to make this happen. And you're right. It usually does work out, but it just drives me crazy hearing that every single time with one particular insurance.
So it speaks ill a little bit of how we've let this system develop, because at the end of the day, a pre-authorization is permission. So now we have made a medical decision. We've trained for years and years, and now we're asking permission to do something. That's really frustrating to me. I mean, we gripe a little bit about Medicare and all that. Actually, their pre-authorization system is a little bit easier, obviously, than private insurance. But when we let other payers in between us and the patients, that was sort of the poison pill that we swallowed. We're not going to change it anytime soon, I don't imagine. But it really does kind of irk me that we are calling somebody to ask for permission to do what's best for our patient, and then we are at their mercy. And it kind of drives me crazy.
They're not telling you, and this is why patients cannot sue insurance companies. They are not telling you what treatment to get. They're just telling you what they will pay for.
Yeah.
And then even when we get the pre-auth, has anyone ever read the bottom of the pre-authorization notice? It says, this is not a guarantee of payment.
Yeah.
Right.
We are approving the service, but not saying that we will pay for it. So they just have about every out that there can be. But let's talk about Medicare Advantage for a minute, because people get pushed into Medicare Advantage all the time. So Michael, I agree. Medicare is actually pretty good with prior authorizations, but Medicare Advantage, does anyone have experience with that?
We have some people call it the Medicare disadvantage plans.
I love that.
Well, my dad actually had Medicare Advantage, and he had a a head and neck cancer diagnosis at the same time. And I had never been exposed to any of this, and it 100% delayed his care to get a cardiology appointment, to get an echocardiogram. Like, it was a mess for him to try and even get into like a cancer doctor to find someone that took that plan. And he ended up having to change it ultimately, but it delayed care by a couple of months. And there's nothing he could do. That's what was infuriating, is we did everything we could to change it.
I don't know your dad, Ellie. I'm assuming he's smart because you are.
Yes.
And then I even think about these people who have signed up for this and they don't have the resources to navigate a change. Or how do I move beyond and get things to work out for me so I can get health care?
Well, that's
Why did they sign up for it? It says 0 payment, 0 out-of-pocket payment, free prescriptions. There is nothing free. There is a price for everything.
Right.
But healthcare is so complicated. Try to figure out these plans. I had to go to the VP of my benefits to help figure out which plan I should sign up for. I was like, I have no clue. What should I do here? So, and we only had 2. It wasn't like there were a lot of choices.
You know what's interesting, though, is that the better system that you're in, you probably don't know the problems that are out there. And if you've got a good staff or a good department that can handle all this, you really only hear about the things that really sort of trickle up to you. So I think it is incumbent on us to know what's going on, to know what that system is, that your staff is working really hard under a lot of pressure, and the patients are working hard under a lot of pressure, and we don't really hear about it until it becomes a real issue. And so those problems are out there. And if you don't know they exist, then I would encourage you to figure out what's really going on with your practice, because it is a problem that you just may have a staff that's super competent and can handle a lot of it for you.
Do any of you, all of you, some of you, do you normally know what insurance they have as you're taking care of them and ordering tests on them? And does that change the way you order?
Yeah, I think the knowledge of it is good for lots of reasons. Like if you're in a breast cervical program and you get a diagnosis that way, you need to know the path that this patient's going to take, that you're going to try to get them onto Medicare and things like that. You can't just go business as usual. Now, when I'm sitting there looking at a patient, I don't care which provider they necessarily have, but I think you need to be aware of what they have, because you set them down a path and all of a sudden you find out that, well, I know they've seen this doctor and this doctor and this doctor, but you've got to have this surgery done in a different state that nobody practices. So you really kind of need to know on the front end, not to be selective as to who you are or are not going to see necessarily, although it may come to that someday, but just to know what the requirements are as best you can know for how best to take care of that patient, whom will see that insurance and the track they're going to take.
One of the things that we do is our nurse navigator touches base with patients prior to coming to see me, and she assesses needs. Sometimes it's just kind of covering what's going on, social issues, but the financial discussion comes up, which, to be honest, is a huge discussion. But I think that helps screen out and identify some of these issues, because I think one of the debates, and my question in this area as well, is I think we all agree that we should be knowledgeable about this and be able to speak with our patients a little, but we're also physicians. And I want to focus on why you should have an axe dissection or not, whether you're a good candidate for a nipple-sparing mastectomy or if you should get neoadjuvant chemo. And while I want to be aware of those financial things, that is not driving any of my decision making. I think there's this sort of balance of like, how much do I want to dive into this and how much should there be other people having these conversations, because these are really important to our patients, but I'm not the person that wants to have that in-depth conversation. And we've talked about that before, right? With lymphedema and sort of the conversation. So how much do you guys go into these conversations with your patients about finances? I love it when our nurse navigator identifies some people and just say, hey, her husband lost his job and they're dependent on her work. And so return to work is important as you have a discussion. And like to have some of that background without it like rehashing something in the visit is so valuable. Or this person's on a grant and therefore plastics may not be covered is really important to know ahead of time. And then Sitcha for you, I know what plastic surgeons accept which insurance. And there's sometimes where people don't get a choice. They're all great plastic surgeons, but it does limit who they may or may not have the opportunity to see. But I do know that information for sure.
I stick to the medical care. That's my expertise. I have a team of people that help with the finances. And if I have to get involved with the finances, the question is, will that change my thoughts as to what I'm recommending for the patient? And in my humble opinion, that plays no role in patient care. Whether a patient's insurance pays for something or not doesn't change our recommendations. Now, it may change what we do at the end of the day, but it doesn't change our recommendations because we believe this is the right course of treatment. Unfortunately, we can come back at a future visit. Unfortunately, your insurance company is not paying for that MRI. So what can we do instead of the MRI? Because you've said you cannot pay for it. Totally understand that these tests are expensive. So now what's plan B? But plan A should never change. And we have to know and document our recommendation regardless of whether the insurance company decides that they will pay for it. Because we don't want to take patient choice away. Maybe it's worth it to them. Maybe they can afford the finances of an MRI, even though their insurance company said they would not pay for it. So I think that we're experts in the medical portion of their treatment, not necessarily in the finances of their treatment.
I think it's important that we are giving recommendations that are evidence-based, and then we deal with some of the other things. And I think it's really also important to realize what people are going through. And like you said, if they're debating between an MRI and putting food on the table or rent, that's a discussion where we need to connect them with people who can help navigate some of those situations, because being safe and secure also has to happen in addition to the cancer care.
Does anybody here think that cuts in reimbursement and or coverage helps in shape the way we use resources in a good way?
It's not a blank check. Earlier on, when everything was paid for, there was this blank check mentality. I think we do have a responsibility to be cost efficient with our patients. That probably is the benefit, the unintended benefit, but the benefit. I think we're well past that now. I think we're looking now is, are we actually restricting access? Are patients unable to get what they need, not whether or not you're going to use this device or give this high-end prescription or whatever it is? I think now we've moved past the cost-cutting aspect. There's only so much blood you can squeeze out of that turnip. And now we're looking at, are we in a situation now where patients are going to be underserved?
This is a big deal because if the hospital's operating margin is 1%, 2%, I mean, there is no investment anyone would make to be like, maybe I'll get a 1% return for all that work. And we have to keep these doors open and we have to keep creating access so that people can get the care they need.
We could talk about this for hours and hours and hours. Before we end this very interesting discussion, let's go around. And my question for everyone is, if you could change one thing in our medical system, what would it be? I mean, Carla looks like she almost fell off of her chair. So I'm starting with you, Carla.
Oh man, I was hoping I would go last. That was kind of my...
After that look? No way.
I will go back to my MBA days and talk about how insurance is set up. And I'm not going to tell you the perfect setup, but I think we need a big restructuring of that.
Ellie?
Price transparency. No one knows how much anything costs. No one knows how much anyone's getting paid. I think radical transparency would help.
Susie?
I think having more case management and social work would be extremely helpful because this is so complex. Any medical problem is not just the medical problem for those people. It's fortunate, but there's a lot of people who need help with long-term navigation.
Sitcha?
Timeliness of care. And I think that's where a lot of it is reimbursement and monetary and financial issue, but it's so multifactorial. And I think partnering with the insurance companies and payers is one part of helping that.
Michael?
Pass.
No way.
Well, if there were good answers, we might have them already. Is a single payer system the answer? Well, I don't know. Look at the places that have single payer systems, and they're in as much dire straits as we are. Healthcare continues to go up on the costs, and there's only so much money to spend, whether it's private or public. I don't know the fix. I just really don't. Retirement, I guess, is going to be my fix.
And here I thought we would solve the healthcare crisis in this 30 minutes, but I guess not. But it has been enjoyable. As usual, I always learn a lot. But to our listeners throughout the breast community, we're so excited you've joined us on this journey once again, and we'll see you next time on the next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
Sitcha.
And Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.